Welcome, everyone, to today's webinar. I am Anuja Vaidya with Becker's Hospital Review. We will begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We are looking forward to hearing your questions. Additionally, in about a week following the webinar, we will be sending you a copy of the presentation to the email you used to register. At this time, it is now my pleasure to start today's webinar by introducing our presenter. Ray Soto is an anesthesiologist who currently serves as the Director of Education and Anesthesiology Residency Program Director for Beaumont Health System and Professor of Anesthesiology at the Oakland University William Beaumont School of Medicine. Prior to coming to Beaumont and Southeast Michigan, completed his undergraduate training at the University of Florida, his medical training at the Uniformed Services University in Bethesda, Maryland, and then served as a flight surgeon and general practitioner with the Air Force in Texas and California. Following his military commitment, Dr. Soto completed anesthesia training at UCLA and then joined the faculty of the University of South Florida in Tampa, followed by a faculty appointment at Stony Brook University on Long Island prior to his move to Michigan. He is interested in patient safety, quality, and education, and his research interests include perioperative patient optimization and standardization to improve surgical outcomes. He has led and been actively involved in patient safety initiatives with the Michigan Health and Hospital Association, Anesthesia Safety, with Quality Improvement Project with NSQIP. He has lectured nationally on patient safety topics and has developed a new national opioid safety scoring system. Dr. Soto, I'll now turn the floor over to you.
Thank you very much for that introduction. As she mentioned, I am an anesthesiologist, a practicing anesthesiologist here in beautiful sunny Michigan. And I was asked today to speak about multimodal analgesia, especially as it pertains to the perioperative surgical home or the enhanced recovery after surgery system. Now, let me try to move the slides forward. There we go. And so this is the title of the talk. Mallinckrodt Pharmaceuticals is sponsoring this. We will be mentioning one of the products that Mallinckrodt does make, but this is not a branded product. This is not meant to be specifically geared towards any one product. So as we know, here in the United States, we spend a lot of money on healthcare, and there's been a big focus since probably 5-6 years ago on trying to improve value-based care. And what that means is moving from a volume-based system where we do as many cases as possible and moving to a system where we do the right operations for the right patients using the right resources. Now, some have called that rationing care. Some have used the terms Obamacare or the Affordable Care Act or value-based purchasing in a derogatory manner, but I think everybody does agree that there are times when we need to make some tough decisions and determine ways in which we can conserve some of our resources to provide the best care possible for the best cost. And so that's really where this national drive is coming from to improve care. Now, what we're going to be talking a lot about today is enhanced recovery after surgery, which really talks about standardizing care. Now, what I always talk about when I start these talks is if you have identical twins with the exact same past medical history and they have the exact same operation in Michigan and in New Mexico, their outcomes should be identical. But that is completely not the case right now in the United States because there's so much variability on preoperative preparation, intraoperative medication management, and postoperative care. At no point am I going to be talking about what type of an operation a patient is having. I'm not going to say you need to use this retractor versus that retractor or robotic versus non-robotic. That's not what we're talking about. We are purely talking about evidence-based practices that can be used in the perioperative period to improve care. And what you really want to do is you want to get a hold of the variability in your system and reduce that as much as possible. So if you have, on this slide here, you can see surgeons 1 through 6 in your hospital, all of which are, let's say, colorectal surgeons, and your hospital is able to pull their length of stay or their complication data, your hospital almost invariably is going to be able to demonstrate that one surgeon has a much longer length of stay or a higher complication rate than the ones that have the lower complication rate or the shorter lengths of stay. And so the idea is, can we move the patients from the surgeons rather, from the left side of the screen to the right side of the screen where that variability really is reduced? And if you can do that in one institution, hopefully you can do that in a system. So for instance, I work in an 8-hospital system where we're trying to do this. And then ideally nationwide, what we can do is reduce that variability nationwide to ensure that outcomes are the same following a gallbladder or a colon operation, again, in Michigan, New Mexico, New York, anywhere, assuming that the patient comorbidities are the same. So the perioperative surgical home model is, it's a branded name that the American Society of Anesthesiologists and the American College of Surgeons have come up with to try to do everything that I just mentioned. The idea is to use evidence-based care to minimize variability, and what that will do is minimize readmissions and complications, which will decrease costs, increase satisfaction, decrease suffering, and increase productivity. And so the perioperative surgical home model, again, is a branded name for this protocolized, evidence-based way of taking care of patients in the perioperative period. So this whole thing came from Europe. So there was a surgeon in Denmark named Ulrich Kellett who started publishing patient data where his colorectal surgery patients, elective colorectal surgery patients, were going home on postoperative day number 2. And they were doing great. They were not coming back with infections. They were not being readmitted. And at the time, in about 10, 15 years ago, the international standard after an elective colorectal procedure was 9 days hospital length of stay. So he was doing something very, very different than everybody else, and people started taking notice. His system, his protocol started becoming, started spreading throughout Scandinavia, and the British took notice of this. And the British sent, the National Health System in England sent a team of anesthesiologists and surgeons to Denmark to try to figure out just what Dr. Kellett was doing to give himself such good results. And they took what they learned back to England, they instituted it as a standard of care in the country, and they tracked compliance with these different protocolized measures, and they tracked outcomes. And within a year and a half, the National Health System found that they had saved tremendous amounts of money, reduced variability countrywide, and saved a lot of money. And they defined that by length, the hospital length of stay saved and complication rate reduced. And if you look at the cost of a day in a hospital in the United Kingdom of $1,053 US, and compared to that, what that costs in the United States at $2,000, it makes sense that if you can save money in England, you can save maybe twice as much money for a hospital system here in the United States. And so it was pretty, there was a pretty quick uptake from Scandinavia to England to here in the United States of these enhanced recovery protocols. And we've had ours in place for about 4 years. We're one of the first here in the United States that really have been going at this for a while, and our results have been excellent, as has everybody else who's really been working on this. So we're going to talk about just what an enhanced recovery protocol really means. Enhanced recovery protocols really talk a lot about the preoperative period, the intraoperative period, and the postoperative period. And as I mentioned, we're not talking about new technologies as written down here at the bottom of the slide. We're talking about integrating what we already know into practice. So for instance, we know that being NPO after midnight is not necessary. So in 1999, the American Society of Anesthesiologists released a consensus statement saying that patients should be able to consume unlimited quantities of clear liquids up until 2 hours prior to surgery. All elective patients, regardless of obesity, gastroparesis, reflux, anything, diabetes, whatever. They can have unlimited quantities of clear liquids, and there's excellent evidence that shows that, number one, it does not cause an increased risk of aspiration or regurgitation or aspiration. It decreases perioperative thirst, decreases hunger, decreases headache, decreases nausea, and probably improves satisfaction. I have surveyed hospitals here in Michigan, and in Michigan, 50% of hospitals are still NPO after midnight, and 50% have some other strange system where they either let people drink certain things or up to 4 hours, 6 hours, 8 hours, they make up their own sort of systems. But it has been very, very clear now for 18 years that we should allow people to drink before an operation. So that's just one example of a simple evidence-based perioperative measure that we can use system-wide, countrywide to improve care of our patients. We've also learned that if you put a carbohydrate in those drinks, patients will have decreased insulin resistance, which will decrease the risk of them having perioperative hyperglycemia, and that applies to both diabetic and non-diabetic patients. And so there's a very robust, excellent body of literature that suggests that if you give people a sugar containing drink up until 2 hours before surgery, their outcomes are going to be better. And so again, not just giving them water to drink, but giving them a sugar-containing drink, whether that be Gatorade or a commercially available drink, is unclear. But giving them something all the time, every patient, will improve their outcomes. Nutritional optimization, it's not on this slide, but it's also very, very important. There's very good data from the American Society of Parenteral and Enteral Nutrition that shows that if you give people immunonutrition products, caloric, protein, arginine products preoperatively, and there are, again, commercially available products that can do this, at least for major abdominal surgery or head and neck cancer surgery, length of stay is shorter, and infectious complications are lower. So again, standardizing these things throughout a system or throughout the country will make sense. It says here no bowel preparation. That is the European version of enhanced recovery. Here in the United States, there is good data that a Nichols-Condon or a standardized bowel prep does work. If you have 6 surgeons doing belly operations, they should all use the same prep. Again, the idea is reducing variability. And then I have here pre-admission counseling at the top of the slide. I think this is the secret sauce of making an enhanced recovery protocol work. We're going to talk about this a lot more when we start talking about pain. But the expectation in America of a surgical patient is that they're going to have no pain after surgery, that they're going to be able to lay in bed afterwards and go home feeling like rainbows and bunnies are happening, and that's really not reality. We really need to provide appropriate expectation management preoperatively, give people the tools they need to understand that they can improve their own outcome by preparing beforehand with exercise and incentive spirometry, and postoperatively by walking a certain amount of distance a day, and again using incentive spirometers and leg pumping exercises to decrease their risk of venous thromboembolism. And that diet, again, in the pre and the postoperative period is very, very different. And we have found, and others have found, and we have published on this now, that patients who are prepared for surgery with a optimization class feel more empowered postoperatively, and their satisfaction is much higher. So by way, again, of a pain example, if a patient's expectation is to have no pain after surgery, but they have 4 out of 10 pain after surgery, they're going to be unhappy. If, however, you tell patients ahead of time, hey, you're going to have 4 out of 10 pain, it's normal, then they will not be unhappy when they have 4 out of 10 pain postoperatively, again, because their expectations have been managed. Avoiding pre-medications in patients who are sedated or demented preoperatively, standardize that. We have that written into our order set that if you're over 70, you do not receive a pre-medication. NG tubes used to be very, very popular when I was a resident. That has been shown to increase the risk of pulmonary complications unless a patient has a partial or full bowel obstruction. So NG tubes really should not be used in the perioperative period. Intraoperatively, using epidurals for open abdominal procedures, that is somewhat controversial now, but standardizing what you do with epidurals I think is very important. Using shorter acting anesthetic agents, avoiding sodium fluid overload. That basically means not saltwater drowning your patients intraoperatively and giving them too much fluid. That is a huge source of variability at my hospital. We have 80 anesthesiologists and 200 nurse anesthetists, plus residents, plus CRNA students. And if I have 3 rooms running, all with the same case, I will go into room 1 and the patient's received 1 liter of fluid. Room 2, the patient will have received 4 liters of fluid. And room 3, the patient will have received 6 liters of fluid for no apparent good reason. It's just kind of what we do because we don't think of fluids as having side effects and we view them as conduits for giving medications. But we know very clearly that the literature is outstandingly solid to show that underhydration and overhydration of our patients is detrimental to health. Small incisions, avoiding drains, keeping patients warm, we know all of those are important parts of good perioperative care, and it's also a SCIP measure. Early mobilization, when I was a resident back in the 90s, nobody got out of bed after surgery until they were mostly healed. That's not the case anymore. We need people to walk. Our physical therapists here were very excited when we started this at our hospital, and they volunteered to help us with this. And so our patients are told preoperatively, and they do postoperatively walk. They sit in a chair on the night of surgery, and starting on postoperative day number 1, they walk a mile a day. And we do that as 20 minutes, 4 times a day, and we have a course mapped out on our floor upstairs, and the physical therapists monitor the patients, and the nurses document it and we audit it to ensure that the patients are actually walking. And they've been told before surgery that you've got to do it or bad things will happen to your lungs, and patients are excited to do it. They're very happy to do this, and it improves satisfaction because, again, the patients are taking part in their own care. We're going to talk a lot about multimodal analgesia here in a little bit. Prevention of nausea and vomiting is very, very important. We found that we started a new same-day joint replacement program here at Beaumont, and we found that the thing that keeps people from going home the same day after their surgery is nausea. And so really getting aggressive about prevention of nausea and vomiting in a standardized fashion is very important. Again, reducing variability. And then we already talked about early oral nutrition. We talked about the importance of nutrition preoperatively, but also it's very important to start people eating postoperatively. Again, back in the 90s when you had surgery, you didn't get fed until you had bowel sounds, and we've learned that you're not going to get bowel sounds unless you're fed. So after our colorectal procedures, for instance, our patients get a clear diet on the day of surgery, and they get a regular diet starting on postoperative day number 1. Again, and that has been shown to speed return of bowel function. And then very importantly, you have to audit compliance and whether patients are doing what you tell them to do, whether the nurses are doing what you tell them to do, whether the surgeons are doing what you tell them to do, and whether anesthesia is doing what they're expected to do. And if something doesn't work, you have to be willing to change the system. So we have meetings once a month here where we go through our entire enhanced recovery protocol for each of our service lines where we're doing this, and we massage our protocol monthly to achieve the best outcomes. So the preoperative piece, we've already talked about a lot of this. I've already mentioned that I think the secret sauce is information management. There are a lot of challenges with information management. Who is going to be providing the teaching? At Beaumont, we learned that we had no nurse educators in our hospital that were dedicated just to providing educational materials. So we had to come up with our own educational materials that were based on good healthcare literacy guidelines. The government is happy to help you with that. There's great websites that talk about how to create appropriate patient materials using the right number of words and the right font and the right number of graphics. I constantly battle the desire of well-meaning nurses and doctors to insert things into my patient education materials that are 50 pages long, single-spaced, black and white, 10 font type. You have to get away from that. It's very, very difficult to keep that at bay. You have to have your marketing folks on the ball. I created an amazing preoperative education booklet for our patients, and the marketing people squashed it because it was not Beaumont compliant. It didn't have the right branding, the right number, right diversity of patients pictured and so forth. So you really have to work with your marketing folks to make sure that everything's compliant with your hospital system. So it takes work. Doing the education piece is work. We hired a person to do specifically this job. We've now expanded this to a preoperative optimization clinic where I have physician assistants down there. They spend about an hour with each patient, not only doing the old school preoperative clinic stuff, which is, hey, have you ever had any problems with surgery? Do you have any allergies to medications? But they also talk about pain. They talk about ambulation. They talk about diet. We give them a nutritional supplement to take preoperatively and so forth. Nutritional optimization we've already talked about. We use a product called Impact AR, which is made by Nestle, which is an arginine containing protein and carbohydrate supplement. Comes in these little juice boxes, and you take one 3 times a day for 5 days. And so when you buy it, it comes in a 15-box carton. You know, the question is really who's going to pay for this? I cheat. I have a grant, so I buy for it out of the grant, and we give it to our patients for free. It costs about $30 to $40 for a 15-box box. You could have your patients pay for it. I suspect that'll decrease compliance with using it. I think that it makes financial sense for the hospital to buy it for the patients. It's relatively inexpensive. And again, there's grade A evidence in the literature published in JAMA and multi-center meta-analyses that show that it works. Exercise and prehabilitation is very important. We have learned, the Canadians have shown that if you increase a patient's exercise at all over a 2-week period, that their outcomes are going to be better postoperatively. And so that's probably what we do the weakest. We tell people to increase their exercise activity every day leading up until surgery. We don't really audit it as well as we should. The Canadians have the patients come in for a 6-minute walk test, which means you measure how far they can walk for 6 minutes. And you do that every few days to see if they can increase the amount of distance that they can walk, and it really motivates the people to get out of their chairs and start walking. And then we do a quick mental health assessment, and we ask people to stop smoking, assuming that we have enough time preoperatively to do that. We know that you need about a month to get the health benefits from smoking cessation, and if you only have a week or two preoperatively and you have somebody stop smoking, all you're going to do is make them mad and make them cough more, which is really what you don't want to have happen. As far as healthcare literacy, I've alluded to this whole concept of patients expecting that they're going to have zero pain. This is a study done by Jeff Affelbaum, repeated by others, that has shown that if you ask a patient, hey, did anybody talk to you about pain before surgery, you can see here in this box that it looks like 63% of patients said, yes, somebody talked to me about pain before my operation. Well, that seems okay, but what it really means is that 37% of patients, nobody mentioned pain to them. The number one side effect that patients are concerned about after surgery is pain. The number one guaranteed outcome after surgery is pain, and yet only 63% of the time do we talk to our patients about that. That makes absolutely no sense whatsoever. I'm always astounded when I ask my gallbladder patients, hey, did anybody tell you you're going to have shoulder pain after your lap chole? And 99% of the time the patients say, no, nobody's ever mentioned that. And if you compare that to how well we are educated when we drop our car off for service, or we go to pick up a new TV and they tell us how all the gizmos work, we do a very poor job of educating our patients on what to expect. And whether that's because the surgeons are afraid to tell the real story, I don't know. Whether the nurses or anesthesiologists feel that it ain't their job to talk about it, I don't know. But there is a hesitancy to give patients a true understanding of what they're about to go through and how long they're going to be out of service. I hear surgeons all the time say, you know what, this is going to be a walk in the park. You're going to be back to your good normal self in 2 days after this operation, when we all know that's probably not true. And you really could do a better job by telling patients precisely what they're going to be going through. And we already mentioned healthcare literacy. We know that it's difficult for people to complete intake forms. It's difficult for people to follow written instructions. So we really do feel that it's important to get people and a caregiver, a loved one, a spouse, or somebody, into a preoperative class for, again, about that hour, so that two sets of ears hear all of these instructions and they both hear what the expectations are for this operation. The intraoperative piece, we know SCIP measures are something that is used nationwide as a means of compliance with best practices. Whether SCIP measures are best practices or not is up for debate, but that is what we have right now. And SCIP measures talk about giving antibiotics 30 to 60 minutes prior to incision, avoiding hyperglycemia, clipping and not shaving hair, avoiding bladder manipulation when possible, avoiding hypothermia, giving beta blockers to the right patients, and avoiding thromboembolism. As I mentioned, NG tubes are bad. As I mentioned, bowel prep should be standardized. As I mentioned, there should be something done to avoid overhydration. There are very expensive technologies available to allow for goal-directed fluid therapy that monitor stroke volume variability or pulse pressure variability to help get patients in the right part of the Starling curve so they've got the right amount of intravascular volume. We don't do that. We don't spend those money for those devices, but what we do is something that we borrowed from other hospital systems that are doing the same thing, is that we put IV fluids on pump when the patient gets to the pre-op area. So the patient comes in from home, they have their IV put in, and that IV is placed on a pump at 3 cc's per kilo per hour. And that is maintained in the operating room and maintained in the recovery room. And you certainly can give the patients a fluid bolus if you want intraoperatively, if you think they need it, but it avoids the patient, accidentally getting a liter of fluid in pre-op and then getting another liter of fluid intraoperatively with induction. And so it really makes people think about the fluid as something that can cause complications, and it has really limited the amount of fluids that our patients have received. Pre-medication, again, if you're old, if you have delirium or dementia, you're not going to get any pre-medicant. We use sevoflurane instead of isoflurane because the recovery is quicker and the degree of nausea is less with the shorter acting anesthetics. We have standardized our postoperative nausea and vomiting guidelines. That has been published in JAMA in 2000, so this is very old data that tells precisely what we should be using for which patients. And then again, we've maximized the use of multimodal analgesia, which again, the latter half of this talk is really going to focus on. And then postoperatively, we've gone through this also. We know, again, early enteral feeding, early mobilization is very important. And again, at the bottom of the slide, expectation management is key. So what we give the patients for a preoperative booklet, for instance, has a little centerfold in it. And in that centerfold, it tells you day 1, day 2, day 3, day 4, ambulation, diet, pain, catheters. And so patients know before they go to the operating room what to expect every day. That is reproduced in poster size on the wall of the surgical floor, so that the nurses see that and they are reminded about that, and the patients have that in their rooms, so they get reminded about that. So again, expectation management, very, very important. It makes the patient participate in their own care, improve satisfaction. They're not going. So we know that pain is bad. So supposition number 1 is that pain does bad things to you. We know that folks who are hurting have an increase in their sympathetic nervous system, and that causes tachycardia and hypertension, which can cause myocardial ischemia, decreases blood flow. It can theoretically cause infection and ischemia. We know that people who are having pain are anxious and they're freaked out and they can't sleep and they aren't able to participate in their rehabilitation like they should. And we know that people who have upper abdominal incisions and upper abdominal pain are going to be splinting, which will predispose you to atelectasis and potentially to pulmonary complications. So we know that pain is physiologically bad. We also know that we don't do a great job of controlling pain. So this slide's a little complicated, but it shows a study that was repeated 3 times, in 95, 2003, and then again 2012. And patients who were having ambulatory surgery were asked, how much pain did you have while you were still in the hospital? So these are patients who were in the hospital a short period of time after their operation because it was ambulatory. And you can see here, if you add up the severe and the extreme, it's about 30-something% of people said they had severe or extreme pain. Now that surprised me when I first heard that, because, hey, I'm an anesthesiologist. I drop my patients off in the recovery room and their pain score is 0 because they're basically unconscious. But then what happens is I walk away, the patients wake up, their pain scores increase. They're ambulatory patients, so we put the clothes on them, we get them walking around, we sit them in a chair, and then we bang them down the hall in a wheelchair. And it's not unusual for their pain scores to increase. And so despite the fact that we know that pain is bad, we don't do a great job of managing that. Now, Warfield was curious about what the incidence of pain was. Jeff Applebaum said, hey, pain is the 5th vital sign. We must be doing a better job. And TJ Gann said, there's this big national focus on patient satisfaction. We must be doing a better job, and we haven't been, basically. So despite 2 decades or 3 decades, really, of focus on the importance of pain management, we're not doing a better job of controlling it. Now, this is, again, a slide that's difficult to work through, but it's a fantastic study done by TJ Gann when he was at Duke University. And he asked patients, I'm going to give you 2 choices. I'm going to get your pain score down to 0. But you know what? You might have vomiting, you might be constipated, you might be itchy, you might be nauseous, or you might be dizzy. Or I can get your pain score down to 4, but you won't have those side effects. Which one would you prefer? And for each case, overwhelmingly, the patients chose to have some pain with less side effects. So again, this speaks to expectation management. Ma'am, after the surgery, you're going to feel like you had surgery. You're going to be sore. I'm going to be able to get it down to about a 4 out of 10 on a pain scale. And if I made it any lower than that, the amount of side effects you are going to have are going to be intolerable, or they're going to lead to you staying in the hospital longer. So you really have to present that to the patients in a matter-of-fact way, so they understand that it's normal to have pain after surgery, And if you make all their pain go away, they're going to have more side effects, which is not a good thing. When we look at what types of medications we give our patients, we in the United States rely very, very heavily on opioids. This is an analysis of a Premier hospital database. Premier is a group purchasing organization that buys medicines. Hospitals buy medicines from them, and they track what is used. And this was a 2012 analysis of a 2012 database, which showed that of 1.5 million patients, of patients who received IV analgesics, 72% received opioid only. We only used multimodal analgesia 28% of the time. And that's not surprising if you think about it. We send people up to the floor, we put them on a dilaudid PCA, and that's it. We give them nothing else. Now, it's very interesting to compare the United States to Europe, and there's different reasons why this might be, but if you look at the amount of pain that patients complain about on postoperative day number 1 and the amount of opiates used on postoperative day number 1, in the United States, we use significantly more opioids and we complain about more pain than the Europeans. Europeans use less opioids and the patients have less pain. Is the cause that Europeans are tougher than we are? I don't think so, but I think that the cause is that the Europeans and other countries internationally do a much better job at multimodal analgesia than we do. So we're going to talk a lot now about multimodal analgesia. Multimodal analgesia means that we're using different medications that have a different mechanism of action and a different site of action to control pain. And I'm going to direct you to one line on this slide here, which comes from the American Society of Anesthesiologists Task Force, which says that unless contraindicated, all patients should receive an around-the-clock regimen of a non-opioid agent. So this is the European way of treating pain. Patients receive around-the-clock non-opioids for 3 days after surgery, and they get opioids on top of those as needed for pain. And we do the opposite. We put somebody on a dilaudid PCA, you call the doc and say, hey, it's not working. You know what, let's give them a little Toradol and see if that helps. So that's backwards, right? That is using a less safe drug first and putting more safe drugs on top of that. So for our protocol, for instance, we give our patients around the clock for 3 days. For our colorectal patients, for instance, they receive Toradol, non-PRN for 3 days, acetaminophen, non-PRN for 3 days, and Neurontin, non-PRN for 3 days. So they're getting 3 medicines around the clock for 3 days postoperatively. And yeah, they do have opioids that they can receive, but again, it is a backup when the other medications don't work. And remember, my patients are told beforehand why it's important, why opioids are not necessarily the best thing to use, and that it is normal to have some pain. So again, decreases the amount of opioids the patients want or expect or need, and it increases their satisfaction. Multimodal analgesia means using different medicines that have different mechanisms of action and different sites of action. We know that, starting from the bottom here, that non-steroidals and COX inhibitors work in the periphery. Local anesthetics work wherever you stick them. We know that opioids work in the brain and the spinal cord, and alpha-2 agonists work in the brain and the spinal cord, and then we know that NMDA receptor antagonists and acetaminophen work in the brain. So it shouldn't be a question of which one should I use, it's a question of what combination should I use. Now, over here on the left-hand side is the good old days of controlling pain. Looked at giving opioids for pain, and if they had more pain, you give them more opioids, and if they had severe pain, you gave them more and more opioids. And hopefully that's not what we're doing, although as I showed in that Premier database slide, it seems to be still the American way of treating pain. What we should be doing is giving, and this is the World Health Organization pain ladder or pain pyramid. This is not something that I made up. If you have mild pain, you give patients these medicines. If you have moderate pain, you give patients the medicines in step 1 and you add low doses of opioids. And if you have severe pain, you do what's in step 2, you do what's in step 1 rather, do what's in step 2, and then you add medicines from step 3. And so you are stacking medicines on top of each other. And one of the things in the world of anesthesia, for instance, that we do wrong frequently is we don't do this stacking technique. So if I'm doing a cystoscopy case, I will give a patient Toradol or acetaminophen. But if my next case is a colectomy, I'm going to skip the acetaminophen or the Toradol and go straight to narcotics. And that's what people frequently do. That makes no sense. So everybody should get acetaminophen, non-steroidal anti-inflammatory drugs, and then you move up the ladder, and you keep adding medicines based on how much pain you think a patient is going to have. And at the top of that pyramid is opioids, and so that should be what you give the least often. And you're giving it in addition to all the other medicines you're giving. This is not just a recommendation by all the subspecialty organizations, but also it is a recommendation of the Joint Commission and Medicare and Medicaid Services through the HRQ. We know that the Joint Commission is very, very interested in opioid-related side effects, and they published a sentinel event warning in 2012, which did a really nice job of explaining the importance of improved monitoring, improved patient screening, and improved use of multimodal analgesia. HRQ has made a condition of participation in Medicare and Medicaid services that hospitals demonstrate that they are doing something to improve opioid-related patient safety. So again, the idea is multimodal analgesia will help with this because it'll decrease the amount of opioids that we're using and hopefully fix the problem of opioid overdose that we see so often in our hospitals. So how do you decide what medications to use? Well, obviously you're going to try to figure out what works for the procedure being performed. That can be tough. As an anesthesiologist, when I was in training, everything was an open operation back in the 90s, and I could look over the screen and see how big the hole was in the patient's belly, and I could figure out how much pain they were going to be in. Now it's a little harder. You know, you need to talk to your surgeon about how much a hand-assisted laparoscopic nephrectomy hurts, or how much a percutaneous such and such hurts. And so it's worth having these discussions with our surgeons so we know how much pain our patients are expected to have. We base it based on side effects of medications. So obviously, if a patient has hepatic failure, you're not going to give acetaminophen. If a patient has renal failure, you don't want to give non-steroidal anti-inflammatory drugs, but you need to tailor your medications appropriately based on the ladder that we've already described. We've already talked at length about this question of ease of use. As needed pain medicines make no sense when we know that patients are going to have pain. So if you know they're going to have pain, why give them a PRN pain medication? Give it to them around the clock, non-PRN, again, using the safest medications available. And then our pharmacists, if there's any pharmacists in the audience, are always very interested in acquisition cost of medications. But I think it's very, very important that we, the leaders of healthcare, really talk about the question of the global value of medications. There may be medications that cost more, but if they can reduce side effects, nausea, shorten stay in the recovery room, and so forth, and improve patient satisfaction, that may increase the value of the medications. So let's just run through some of these different multimodal analgesic drugs that we have. So acetaminophen, we know, has been around since the 1800s. It works very well for analgesia. It works in the brain. The reason that Norco and Percocet and Vicodin all have acetaminophen attached to the opioid is because it works. We also know that acetaminophen in the perioperative period works. It decreases pain. We also know that there's 3 formulations of acetaminophen available. One is oral, one is rectal, and one is IV. Rectal acetaminophen is poorly absorbed, and when you look at the plasma concentrations that you get after giving the recommended dose, you never or almost never achieve analgesic concentrations for rectal acetaminophen. However, oral and IV do work, but IV gives you plasma and CSF concentrations much quicker and much higher than you would get if you're receiving it orally. And when people ask me about the question of oral versus IV, I always say, look, why do we give Zofran IV at the end of the case instead of giving them a pill of Zofran preoperatively? Because it's available, same dose. Why do we give antibiotics 30 to 60 minutes before incision instead of giving them a pill before surgery, which we could do? And the answer is simple. It's because we want predictable concentrations at the effect site, and that is the chemotactic trigger zone for Zofran, that is the skin for antibiotics, and that is the brain for analgesics, especially acetaminophen and medications like that. So giving IV analgesics makes sense, and giving it at the right time makes sense as well. Alpha-2 agonists, we're not going to talk much about those. They do work to decrease pain. Those are primarily used to improve sedation practices and extubatability in patients in the ICU. Gabapentinoids, if you are not using gabapentinoids routinely, for major operations in 2017, you are absolutely categorically behind the times. So if you are at a hospital and you're not using a lot of Neurontin or Lyrica for your patients in the perioperative period, you need to take a look at your practice, because that is not evidence-based anymore. So big meta-analysis data shows that if you give perioperative gabapentinoids, you decrease pain, decrease opioid use. So we start that preoperatively for our enhanced recovery patients, and we continue that for 3 days, again, non-PRN postoperatively with some restrictions based on renal function and age. Local anesthetics. We know there are new formulations of local anesthetics coming out that work longer. Things like Exparel work 48 to 72 hours. I'm a huge fan of intravenous lidocaine. There's very, very good evidence that shows that IV lidocaine infusions intraoperatively and postoperatively decrease opioid use, shorten length of stay, improve patient satisfaction, decrease anesthetic needs. So it's a great drug to use. Hospitals tend to be a little skittish about allowing IV lidocaine on the floor because they think, quote unquote, it's a dangerous medicine. But I will suggest that it is much, much, much safer than giving Dilaudid on the floor. And so we use that here at Beaumont, actually. We use IV lidocaine infusions for up to 48 hours postoperatively on the floor. And we can talk afterwards about the dosing if people are interested. Ketamine, that's another drug. If you're not using it in your perioperative patients, there's, I was going to say there's something wrong with you. That's not a nice thing to say, but you are behind the times and you are not practicing evidence-based medicine. We know that NMDA receptor antagonists, again, big meta-analyses have been published to show that giving them in the perioperative period decreases pain, decreases opioid consumption, and decreases postoperative nausea and vomiting. So if you have a patient that you think is going to have pain afterwards, you need to consider adding ketamine to your pain ladder. Non-steroidals, a lot of non-steroidals available both orally and intravenously, and again, these should be continued postoperatively in a non-PRN fashion, as we discussed. Now, the next few slides are a sample protocol. I'm not going to run through these slides. I'm going to go through these super fast because we've gone through all of this already. This just talks about my protocol, but we do a nutritional assessment. We give the patients the nutritional products that we talked about, and we've discussed everything else on this slide already. Goal-directed fluid therapy and anesthetic optimization we discussed. I'll leave this slide up just for a second so people can see what my IV lidocaine protocol is. We give 1.5 milligrams per kilogram with induction, which is the sympatholytic dose of lidocaine. And then we run 2 milligrams per kilogram per hour until emergence, and then afterwards they are run on 1 milligram per kilogram per hour for 24 to 48 hours. We talked about multimodal analgesia, and we've gone through the gabapentin and the ketorolac. This is my ketamine dose. I give 0.5 milligrams per kilogram with induction of anesthesia. The literature supports up to 1 milligram per kilogram with no increase of postoperative side effects in these patients. It doesn't matter if you give it as an infusion or a one-time dose or split doses in the OR, as long as you give it. Especially if you're giving a lot of narcotics, ketamine will decrease some of the acute tolerance effects that we're discovering with these medicines. Very, very important. And then we've talked about all of this as well. So this is the concept of this whole program. If this top dotted line is your patient's baseline level of function, and this is the minimum level of function that you need somebody to get by in their everyday life. You have Granny here on the left side, and she's found to have a tumor on a colonoscopy, and they tell Granny, hey, you're going to have your colon taken out in 2 weeks. You give your patient no education whatsoever. She gets depressed. She stops eating. She sits on the couch. Her level of function goes down. We do a big old whack on her in the operating room, and then she slowly recovers, and guess what? Granny was just never the same after her operation, and we've all heard that. So the concept behind this Prehabilitation enhanced recovery protocol is that you bulk Granny up preoperatively with nutrition and exercise and education. You minimize the intraoperative stress that the patient is having, and then you have a quicker recovery, and she will achieve these higher levels of functional capacity postoperatively. And again, what that will do is it'll shorten length of stay, reduce the risk of side effects, and improve satisfaction. So we can talk about this again in the question and answer period, but this is not easy. This takes work. Me sharing my protocol with you is not going to make you instantaneously able to implement this in your hospital. It took us about a year to implement this, and you will learn that you don't know what you don't know. So for instance, when I started talking about postoperative exercise and ambulation, I learned that the nurses had no mechanism of tracking how far or how much patients walked. There was no entry system in our Epic computer system to do this. So we had to build that. How did we ensure that patients take their nutritional supplement? How do we get this? Who pays for that? All this takes time. So you really need to first identify your surgery, anesthesia, nursing, and administrative champion. That is step one. Get those 4 people in a room together and make a commitment that you are willing to do this. And then you form a larger working group to develop the evidence-based guidelines to do enhanced recovery for colorectal, for cystectomy, for orthopedics, for whatever operation you think is important. I think it makes the most sense to target long length of stay procedures. Some people want to talk about doing this for bariatric surgery, for instance. The problem with bariatric surgery is those patients do great. It is heavily protocolized. The patients go home the next day. They have very little pain, very low complication rate. So why not focus on something like colorectal surgery, esophagectomy, which has a 30% major complication rate, cystectomy, pancreatectomy, and so forth. Your hospital, I did not know this, but my hospital does an amazing job of tracking length of stay and readmission rates and surgical site infection and satisfaction and variability. So I was able to get this information in 15 minutes when I asked for it. I was expecting it to take months for me to get this data. So your hospital is already gathering this information so you can have baseline information to base your improvements upon. Generate your protocol with a bigger working group that includes a pharmacist, a nutritionist, a physical therapist, a marketing person, a satisfaction person, etc. And then again, we already talked about this whole concept of reanalyzing your data and massaging your protocol as time goes off. And I believe that is it. I'm going to leave this slide up here as I'm taking questions, and I would like to direct you to these links. You can see here there's the middle one, the Enhanced Recovery After Surgery Society, is a European society. The bottom one is EBPOM, is a British society, and then the top one is the American Society for Enhanced Recovery. My conflict of interest is that I'm the treasurer of that society. We meet every year in April in Washington, D.C. I would recommend everybody go to that website and check it out. It's a fantastic meeting. It's the only meeting that I go to that is multidisciplinary. About a third of the audience is anesthesia, about a third is surgery, about a third is nursing. And we really do a great job of kind of boiling down to what the best ways are of taking care of a patient from a multidisciplinary approach. If you go to the website, you will find example protocols, example patient education materials, and so forth. And so again, I would recommend highly that anybody interested in this topic visit these websites and join us in Washington, D.C. here in a few months. And that's what I have.
Well, thank you, Dr. Soto, for that. Yes, thank you so much, Dr. Soto, for that fantastic presentation. Well, we will now begin today's question and answer session. Please submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We will try to get through as many questions as we have time for. We've already received a few questions about receiving some protocol information and resources. We can share your information with Dr. Soto, and he can follow up with you regarding those. Now we'll jump into our first few questions over here. So the first question for you, Dr. Soto, is what database are you using to track compliance and outcomes?
Yeah, you know, so there's two. When you're looking at data, there's two parts of the data you have to look at. One is length of stay, surgical site infections, complication rate. That is all done for you by your hospital already. If you are a NSQIP participating hospital, National Surgical Quality Improvement Project hospital, you have this data already available at your fingertips. So you should be able to pull that data very quickly. Whenever I give my hospital number crunchers a list of medical record numbers for our patients, they're able to, within a day, I just did this Friday, within a day they're able to get me a list of length of stay, and they're able to give me case mix indexing and so forth. So your hospital already does that part. The harder part to track is compliance. Did the patients do their drink? Are they doing their exercise? Are they walking postoperatively? And what we started with for the first year or two of doing this is we started using something called a paper and pencil because we didn't really have a tool to do this other than making medical students walk around and track it on a piece of paper, and then they would type it into an Excel spreadsheet. What we've been able to do since then is work it into our Epic system. So our Epic hospital database now, it has a lot of these points, and it's still not the easiest thing to tease out, but we have some folks that can pull this information out when we need it. And our PAs down in our preoperative clinic are the ones that pull that information when we need it.
Fantastic. Great. So our next question is, are you concerned with gastric emptying when using Impact?
Am I concerned with gastric emptying when using Impact? So Impact is, it has kind of the consistency of a milkshake, and it is used once a day. I'm sorry, it's used 3 times a day for 5 days before surgery. So the last drink of Impact is the night before surgery. So it is not part of the clear liquid preoperative carbohydrate loading thing. People frequently confuse carb loading and nutritional optimization. Those are 2 separate things. So Impact is part of the pre-op thing that ends the night before surgery. And then for carbohydrate loading the morning of surgery, we do the clear liquid Gatorade type drink for the patients. And so I'm not concerned with that.
Great. Thank you for that insightful answer. We have an audience member who'd like to know the website of the education material guidelines you referenced.
Yeah, so they should have it on the slide right there. So acerhq.org is the American Society for Enhanced Recovery website, and again, I'm part of the organization, so I'm happy to say it's a great website. It's got amazing information, and if you become a member of American Society of Enhanced Recovery, there's an implementation guide that we have published that runs through everything that we've just talked about in detail, and includes all of the evidence for different types of surgery.
Fantastic. And another audience member would like to know the name of the drink you spoke about and where to order it.
So Impact is the preoperative nutrition drink that we talked about, which is the 15 little juice boxy things, and you can get it on Amazon.com if you want to. I'm sure your hospital has a better way of ordering it. It is made by Nestle. My understanding is that there are other products available. My hospital is a Nestle hospital. Again, you don't know what you don't know, right? So I didn't know that hospitals are either Nestle hospitals or Abbott hospitals when it comes to nutrition and baby food and stuff like that. So we use the Nestle product. Again, you can get it on Amazon if you want to, and it costs about $30 to $40 for a 15-bottle course of the stuff.
Okay, great. So our next question here is, since Europe does mostly open colorectal surgeries, the use of epidurals is much more common than in the U.S. Do you think that is why the European patients have less pain, POD1? I think they're referencing slide 18.
Yeah, I'm going to challenge that comment a little bit. The Europeans do a significant amount of, they probably do the same amount of laparoscopic procedures that we do. And the Europeans do use less epidurals than we do. If you look at the European literature, there is a big move away from epidural analgesia because epidurals, they feel, number one, increases the amount of fluid a patient gets in the perioperative period, and we know that overhydration can be bad, especially at the anastomotic site. Epidurals keep you from walking as well as you should be able to walk postoperatively, and epidurals keep you from losing your Foley catheter frequently. So the Europeans are moving away from epidurals. There's great literature that compares epidurals to tap blocks and compares epidurals and tap blocks to IV lidocaine infusions, and they all seem to be equally efficacious. The Canadians really have moved away from epidurals for their open procedures, and they're much more, they've been using a lot more intrathecal narcotics, one-shot intrathecal narcotics preoperatively to try to decrease that opioid requirement for the first 24 hours. Here in the United States, we still do a fair amount of epidurals for our open cases. I told you we do that here in our situation, but as we start doing more and more lidocaine infusions, I think we're going to be moving farther and farther away from epidurals.
Fantastic. So our next question is, does your facility use IV ketamine infusions postoperatively on your inpatient units?
At the same time that we were fighting the IV lidocaine fight, we were trying to decide whether we should fight the IV ketamine fight, and I had a resident do a big literature review for us, and it seems as if the literature for routine postoperative use of ketamine infusions is weak. And so because of the relative lack of evidence-based literature for routine use of ketamine, we chose not to pursue that. So we don't do that. Does it work for ICU patients? Yeah. Does it work for people who are tolerant to narcotics? Yeah. But for generalized use, which is how we're trying to make our protocol as generalizable as possible, we chose not to pursue that.
Okay, excellent. Another one of our audience members wants to know how are you tracking outcomes?
So again, we're tracking outcomes as defined by length of stay, surgical site infections, anastomotic leak rate, hospital readmissions and hospital revisits, and patient satisfaction. We use what our hospital has been doing for years. So the hospital gets some information from the National Surgical Quality Improvement Project. Here in Michigan, we have something called the Michigan Surgical Quality Collaborative. A lot of these states have surgical collaboratives that give them patient data. And then every hospital tracks satisfaction and length of stay and readmission in different ways. And again, as I mentioned, I can get that information from my number crunchers. I wish I could tell you what their job title really is. I know what the guy's name is that I email, and he gets me information within 15 minutes about whatever I ask for. So the hospital has it readily available. Again, this goes back to you don't know what you don't know. Your hospital tracks information. You just have to be able to leverage that information to improve patient care as best as possible.
Question is, do you have any strategies to relatively short stay surgery, such as total joint replacement?
So, we talked about implementing these big protocols. I don't think you necessarily need to have meetings and generate huge protocols for short stay surgery, but a lot of what we've talked about, I think you could apply. Number one, last coli patients, why not tell them about pain? Why not give them realistic expectations of pain preoperatively? Why not postoperatively tell them to take Motrin and Tylenol around the clock for 3 days, and if you need to, take this opioid. Now, part of the problem with that is we give these patients Vicodin to go home with, or Norco, which has acetaminophen in it. It would be great if we can give moxicodone instead, and there's many reasons why people don't do that, but giving them appropriate expectations beforehand and telling them what to do postoperatively in a standardized fashion makes sense for the short stay operations as well.
Okay, fantastic. Our next question is, how do you view a colorectal bowel surgery SSI bundle interfacing with an ERAS protocol?
What was the question? Can you say that one more time?
Oh, sorry. Sure thing. How do you view a colorectal bowel surgery SSI bundle interfacing with an ERAS protocol?
Well, SSI is surgical site infection, and many yes. So an SSI bundle is a way of trying to reduce the risk of surgical site infections. I think it interfaces naturally because a lot of the ways of improving infection rates, temperature control, giving antibiotics at the right time, nutrition postoperatively, ambulation, deep breathing, and so forth, all are tied together. So I think it should be a part of the larger whole. And we have done that. We have had to, we have a bladder bundle, we have the SSI bundle, and so forth. So I think it just naturally flows together. Again, we meet once a month to talk about our protocols, and we always have guest speakers who come in that want to know how we're doing things, and we always learn from them how they're doing things, and then if it makes sense to tie into our protocol, we'll merge the two.
Okay, fantastic. So it looks like we have time for one more question. Do you alter the dose of IV lidocaine for patients who have received nerve blocks and REK injections?
Who have received what and what?
I'm sorry. Do you alter the dose of IV lidocaine for patients who have received nerve blocks and REK injections?
I think that is a question that should be handled offline because I don't know the answer to that question. That person clearly knows more about lidocaine than I do.
Okay, fantastic. Well, that is actually all that we have time for today. I want to thank Dr. Soto for his excellent presentation and to our audience for participating today. Enjoy the rest of your day, and we look forward to having you join us for future webinars.